2021. So May 21st, and we are getting ready to perform a Deuk laser disc repair endoscopic surgery. This surgery is done through a tiny incision on the patient's back. The surgery is done endoscopically, and currently Deuk Spine Institute is the only place in the world you can go to get a Deuk laser disc repair. And we're located here in Orlando, Florida, in sunny Florida. Our patient is suffering with back pain and right leg pain. I'm going to talk to her for a moment. Good morning. Are you awake? It's Dr. Deuk. We're going to get started, okay? If you feel pain, I want you to say ouch, but don't move your body around. Keep your body still, all right? And just say ouch and tell me if the pain is in your back or leg. Say ouch, back, or ouch, leg. And then we're going to put you to sleep as soon as I can. That's just my hand probing around, all right? I'm going to give you some numbing medicine. You're going to feel a little stick and burn. That's normal. Don't freak out. What is she saying? I'm going to have our anesthesiologist listen in, and he can relay what you're saying.
What did you say? You have a neck problem?
Is your neck uncomfortable? I can't really hear her, so.
Problems all over, is our saying? Are you comfortable to lay here for a while?
Do you want to reposition your head a little bit? You think she's too hyperextended? All right, we're going to get your neck a little more comfortable. So folks that are watching, our patients are awake for the very beginning of the surgery. Of course, I'm going to put her to sleep soon, but I need her awake for the beginning. And patients are only awake for lumbar. They're not awake for the cervical or the... They are awake for thoracic as well, which we don't do very much of, but there's really three parts to the spine that have problems. Cervical, which is the neck, thoracic, which is the middle of the back, and then the lumbar, which is the lower back. The most common by far is lumbar. And what we're treating is a herniated disc and with an annular tear. Let's go lateral, please. And basically, we're going to be using what's called navigation. And navigation today means the same thing it meant hundreds of years ago, which is to go from one place to another, origin to a destination. And the navigation is done using the X-ray machine. That's pretty good, actually, for you. I need to be a little bit lower, just a little bit. So we use a X-ray machine to navigate. Everything's fine. Just lay still. You're doing really good. Shut. So if you just look at a patient's back, you can't really navigate to where you need to do the surgery without some help. And that help comes in the form of a X-ray. And that's what I'm using right now as an X-ray machine to get to the right spot. And the right spot is that L4-5 disc right there that I'm headed towards. You're doing great. We're almost done, okay? We're almost done with the part where you need to be awake. Shot. And the way we get to this disc is we're using a spinal needle, which is what I'm doing right now. Shot. Any pain? She awake?
Are you hurting, Rita?
Oh, she's nice and awake. Shot. Let's get an AP. So if you look at the needle coming from the right side of the screen, it's aiming right towards the L4-5 disc between those two vertebrae, which look like squares or rectangles. And the disc is herniated out backwards into the foramen. She has a little bit of scoliosis, but not that much. All right, so the needle is in perfect position. If you look at the pedicle of L4 and L5, it's exactly where I want it to be. You doing all right? Now I can actually feel the herniation with the tip of this needle. We're going to put you to sleep in about 2 minutes, all right? I feel the herniation. It's right there, Sean. And we're going to get rid of this herniation, and we're going to fix her back pain and her leg pain, both, with this surgery. Are you comfortable? Okay. Now, the L4-5 disc is located. I'm going to draw on your back a little bit, all right? So you get to watch this later and you get to learn something if you don't already know it. The L4-5 disc is, I'm going to draw where it would be if it projected to her surface. Her surface is her skin, obviously. So this is the disc. Can you all see this thing here? And it's literally located as a cushion between two bones, the L4 bone, which is right there. This is the number 4. And there's another bone right here with a flat surface. That's called the end plate. And that's the number 5 bone. And this is the L4-5 disc, all right? She has a tear in this disc right here on the right side, and it's allowed the jelly from the center to move out and what's called a herniation right here. And that's what our target is the annular tear and the herniation. Not one or the other, both. The most important thing to get rid of is the annular tear. We want to clean the annular tear with a laser, and that's going to get rid of her back pain. Did you get a shot or not? I don't think so. There it is. All right. Are you comfortable? Yeah? How bad is that on a scale of 1 to 10? Huh? 10? All right. I apologize. I had to test the disc. Okay. We get to go to sleep now. Please count from 1 to 100. Now, folks, look at the x-ray. And you can see where the needle enters the disc, in the back of the disc. We go right into the tear. And I injected that dye, and it all leaked out through the front and the back, but mostly the back. You can actually see the herniation back there. It looks like kind of a side profile of let's just say a buttock. There's another body part I could have said, but you can see a double shadow. I'm not going to say it, but you can see it's like double curved, like 2 mountains next to each other, 2 hills. And so those are the herniation sticking out, by the way. And the dye, the black dye, is kind of filled in there into the herniation and got stuck in there. And so you can actually see the herniation on that view. And the needle pierces right through it. And then you go into the disc part where all the dark, dark, dark stuff is, and you can see how big the tear is back there. So she had 10 out of 10 pain. She said 10 out of 10, typical pain, where she typically gets her back pain. Can you count from 1 to 100 and lay still, okay? All right, I just started picking her head up. All right, so we're going to take the needle out. You can see it, leaving the guide wire in. I'm going to make an incision first. An incision, the whole surgery, folks, is done with an incision that's 7 millimeters. 7 millimeters. Can you imagine having your back surgery done with a 7 millimeter incision? By the way, 7 millimeters is small, in case you're wondering. Is that big or small? Okay, that's small. If this patient was having an open back surgery, I'm going to show you her back surgery, her incision would be that big as the pin. That's huge, okay? But instead of doing that kind of incision and going up the middle and then taking all the bone and ligaments out, we're going from the side. And we're going through a hole that's already there called the neuroforamen. Now it's kind of funny because I see posts being done these days by spine surgeons that are like starting to do endoscopic surgery like this, and they say, oh, you know, I'm one of the first ones doing this. No, you're not. I've been doing this for 15, now going on 16 years, right here in the good old US of A. So I just have been doing it kind of quietly. Now, we've been broadcasting these surgeries for 8 years. So of course I want them and the public to see the surgery and ask questions and learn how to do it. But it's funny because you're kind of seeing surgeons for the first time doing the surgery that we've been doing here at Deuk Spine now for many, many years. I've been doing this endoscopic surgery myself for 16 years. Even though the surgery center is only 8 years old, I was doing it in our office surgery center before. All right, so the dilator is in, it's inside the disc. I went through the tear and the herniation. I actually pushed the herniation back into the disc. It's safer and easier to take the herniation out from inside the disc rather than inside the foramen where the nerve root is. So this is called the inside-out technique. Dr. Anthony Young taught this to me. And there was a big kind of debate going on for years. This was back in the early 2000s. So this is like 20 years ago, 15, 20 years ago. There was a debate between, say, Dr. Young and Dr. Knight over in Europe, who does the outside-in technique, where he starts in the foramen and then works his way into the disc, which is much more dangerous and risky in my opinion, and the results are nowhere near as good. Dr. Young has always been a proponent of the inside-out technique, starting inside the disc and working your way out, which is what I've done my whole career of doing endoscopic surgery. Important distinction: anyone who wants to stay true to my form and technique should start inside the disc. And you get better results and you get safer surgery. Now this is over 1,300 endoscopic surgeries I've done, and that of course pales in comparison to Dr. Anthony Young, who's done over 10,000 of these surgeries, but he's not done the Deuk laser disc repair. See, Dr. Young has done a surgery where he removes the herniation, but the Deuk laser disc repair is my creation. That's where I remove not just the herniation, but I also clean the annulus, debride the annulus with the laser. And it's really important distinction because other surgeons that do transforaminal endoscopic surgery, they don't do an annular debridement like I do. You must use the laser and you must do the annular debridement if you want to cure the patient's back or neck pain. A lot of surgeons will just use the pituitaries, the metal instrument you just saw me use, or they'll use what's called a radio frequency probe, and those don't work very well. I'm pretty much the only one that does a straight firing laser, and I've used this laser, same laser, since I started doing these surgeries 16 years ago. And people ask me, why don't you use a side firing laser, or why don't you use a radio frequency probe? No, there's no benefit to those. They're actually worse, and they're also more expensive. So why would I use something more expensive? The people that want me to use a radio frequency probe and the side firing laser are the ones who sell the radio frequency probes and the side firing laser. I'm not interested in padding their pockets. I'm interested in curing my patients for the, most cost-effective way possible and the safest way and the most effective way possible. So, you have a question there, Sean?
Yes, we have a couple.
Let me just say a few more things and then I'll take the questions, all right? So for those of you who have never watched this surgery before, we are inside a tube. And that tube I put in a minute ago, and it's inside the disc. So one end is out here where I am in the operating room. The other end of this tube is literally inside the patient's disc, the L4-5 disc. And this is the disc that needs to be fixed. There's a little bit of schmutz on the lens, so I'm going to take it out and clean it so we can have a better view, because I like, crystal clear vision. And we have the top of the line endoscopy system, so there's no reason we should shortchange ourselves by allowing it to not work at its full performance. All right, so we're inside the disc. Left and right at 3 o'clock and 9 o'clock are the end plates. If you know your anatomy, we're inside the disc. You're looking at the end plate of L4 and L5. Specifically on the right is the inferior end plate of L4. On the left is the superior end plate of L5. Dead center at 12 o'clock, just outside the tube is the annular tear with the interposed nucleus pulposus. That is our target. And then, of course, you see the metal will show you the blast marks of the laser. So for people who doubt what the laser can do, oh, it can't cut through bone spurs, well, look, it's cutting through steel. So, of course, it can cut through bone. Whoever told you it can't cut through bone lied to you. All right? There's a lot of misinformation out there. See the tear? One end of the tear, the other end of the tear, and right in the middle is the herniation that's stuck in there. That's what we're here for. This is the Deuk laser disc repair. It's the only... Hello? It's the only surgery... My staff are mesmerized. It's the only surgery in the world that repairs the annular tear. And that's because I created the surgery. I found it. It's all FDA approved. There is nothing we use that isn't FDA approved. So it's 100% legal, FDA approved. The surgery has been peer reviewed and published several times, at least 5 or 6 times now. I've lost count. I've presented and published this surgery at the American Association of Neurological Surgeons, the Congress of Neurosurgeons, the Society for Advancement in Minimally Invasive Spine Surgery, the Florida Neurosurgical Society, and the Southern Neurosurgical Society. So, I've also presented in Hong Kong at the Synthes meeting. I forgot what they called that meeting, though. So it's not like other doctors don't know about it. They know about this surgery. So why don't other doctors do it? Well, number one, they're not trained, and training takes a long time, like about a year, and they don't want to spend a year learning. They don't want to spend a year of their life for your benefit. Unfortunately, they've already put in many years for your benefit and their benefit, and now when it comes to actually doing a surgery that's going to pay them less, they don't want to come over here and spend the time learning because they're going to get paid less. So unfortunately, this type of surgery pays the surgeon less money than open surgery. Open surgery pays a lot more money. So a lot of surgeons aren't interested in learning this surgery because they're going to get less money. But that shouldn't be why you have surgery. You shouldn't, as a patient, you shouldn't base what surgery you have on based on how much the surgeon makes. That would be a really bad decision. All right, so this is the tear right here. You can see it. And there's a piece of herniated nucleus pulposus just scarred into that tear. So I'm going to zap it away. Go ahead. Let's take some questions.
All right, our first question comes from the Deuk Spine Institute app. One of our viewers is wondering, after this surgery, can you do activities like golfing or going to the gym anymore?
Oh, yeah. Great question. So one of our viewers through the app is saying, after you're done with the surgery, can you go back to a normal life? And the answer is 100% yes. That's why we do this surgery, so you can go back to a totally normal life. Now, when can you go golfing? When can you go skydiving? When can you do all these things? At the right time. And the right time, basically, to give you a simple answer, a lot of the heavy activities, heavy lifting, bending, twisting, or contact sports, you're looking at a year of recovery, 6 months to a year of recovery. Depends on how fast you heal. Slow healers, a year. Fast healers, 6 months. But the reason for that is, yes, your skin incision will be healed like in a week, and the muscles will be healed in a week. But the disc itself, this right here, this tear down here you're looking at, that literally heals very slow. And honestly, I can't make it heal any faster yet. I have some ideas to make it heal faster, but the God's honest truth is, got so much on my plate to do these days. It's hard for me to really do more research, and I have something that I want to start using, but that could probably heal things quicker, but I haven't started doing any testing or experimentation. But for the time being, your body heals it just fine. It just takes time. So can you go back to all the activities you want to do? Yes, 100%. Can you go back the next day? No. You have to pace yourself. And we will give you a protocol as to when you can go back to doing things that you want to do, okay? But basically, everybody is up walking the same day. They're literally up walking an hour after your surgery. And the only reason you're not walking the first hour after surgery is the anesthesia. So you're groggy and sleepy. But from a surgery standpoint, I could literally do this surgery right now and pull this tube out, and then this patient could walk out of the operating room. They're just sleepy from the anesthesia, that's all. So the recovery is almost immediate, unlike traditional spine surgery, where the recovery takes much longer. Ooh, look at that. Oh, that is cheddar right there. That's your granulation tissue on the outside of the annulus. That's where all the pain fibers are. That's what's causing all the pain right there. Say goodbye. Or better yet, say hello to my little friend. All right, you have another question?
Yes, we do. Another viewer on Facebook is wondering, I saw on the last case that 4 of the discs look herniated on the MRI. Why would surgery only need to be done on 2? And why do some people have symptom-free herniated discs?
Great question. My gosh, I love it. So the person who's asking the question comes from YouTube, you said, or Facebook?
Facebook.
Facebook. So one of our Facebook watchers has made a very good observation that, hey, the last patient you did 2 discs, why did you not do all 4? Because all 4 looked herniated. The answer is you are correct. All 4 are herniated. However, only 2 of them are causing pain. So that's the reason we don't fix the other 2, is they're not causing any pain. How do I know that? And that's where the physical exam comes in. Remember I told you guys so many times on these videos, you can't make a decision based on an MRI because MRIs don't tell you where pain comes from. Only the patient can tell you where pain comes from. That's why the first thing I do with my patients and when I see them is I ask them, put one finger, just one finger on the place where you have the worst pain. That's literally what I do to every single patient. And that is probably the most important thing I do to every single patient. Because the patient is the one who feels the pain, not the doctor. And you got to have your patient show you where their pain is. Now, when that patient that we just did showed me her pain, she pointed to L4-5 and L5-S1. She did not point to L2-3 or L3-4. And then I asked her in clinic, do you have pain up here, higher at L2-3, L3-4? She said, no, I never get pain up there. So the patient is the most important diagnostic tool we have to figure out where their pain's coming from. And you never want to treat a disc herniation that doesn't cause symptoms. It's unnecessary. Honestly, I mean, I do brain surgery without stuff like that happening. Why is that happening? Uh-huh. So we just had we use a pressurized saline irrigation, and one of the pressure bags just popped. What's that? It was still in the working range? All right. I know, but I like to solve problems. As in, why did it happen? All right, so getting back to what we were talking about. We don't operate on things that don't look normal but don't cause problems. So the answer is we fix disease. As doctors, we fix disease or prevent disease, right? So those discs that are herniated are not causing any symptoms. They're not really disease. They're just a structural abnormality that's not a disease. I like to use the example of wrinkles. If you have wrinkles on your face, which we all get as we get older, those wrinkles are not disease. They're not part of a disease process. You leave them alone. Unless, of course, you don't want them. Then you have plastic surgery. But there is actually a disease from wrinkles. Does anyone know what it is? And the only time you operate on wrinkles is when a patient has the disease from wrinkles. So what is that disease? Okay, I'll tell you. It's when the wrinkle is around the eye and it closes your eye so you can't see. In other words, the wrinkle's so bad, it literally affects your vision and you can't see. How do I know about this? Well, it's a true condition. When wrinkles affect your eye and your vision, you have to operate on them and get rid of them. So we don't operate on wrinkles unless they're causing disease, which is, affects your vision. We don't operate on herniated disc unless they're causing disease, which is back pain, neck pain, and leg symptoms. So that's why we left those discs alone. You know, if I was a bad person, I could tell the patient I need to operate them and take more money to operate on. But the truth is that I can't make the patient any better by operating on those discs. So will those discs become painful in the future? Will they become diseased? The answer is most likely no. 95%, 99%, no, they won't. So that's why we don't operate them, because they're not causing any problems for the patient. And by operating on them, I could end up hurting the patient more than helping them. So there's no reason to operate on those other herniations, because they're not going to make my patient better. And they're not going to prevent disease, because those discs rarely ever cause pain. I hope I explained that well enough. And then, why do people have herniated discs that are not painful? The reason is, so I'll give you number one. Nobody knows 100% for sure, but I have a very good idea as to why. The reason why is that it's not the tear or even the herniation that causes the symptoms. It is the inflammation that's occurring around the tear and from the herniation that causes the symptoms. So some people are able to heal their tears and their herniations with scar tissue, collagen basically, that surrounds the nuclear herniation and prevents inflammation. So kind of like if you get a thorn in your finger, some people are able to have that inflammation or the pain for a little while, and then it forms scar tissue around the thorn, and then the thorn is now pretty much outside your body basically. Because anything that's encased in scar tissue, is your body feels like it's done its job and it's no longer necessary to fight it. But in a lot of people like this disc right here, the inflammation keeps going on and on and on. Now look at this. Sean, this is a really good picture right here of, see all the pink color? That's all granulation tissue in the outer part of the annulus. Sean and Zach, this would be a great picture for the website, but to explain the inflammation in the outer annulus. You could see all the redness and swelling, and that's where the pain comes from, and that's what we're getting rid of. Another name for it is in the south is proud flesh. Coming from California, I had never heard of proud flesh before, and I got to the south here to do my residency in neurosurgery at the University of Florida in Gainesville. Pretty much the top neurosurgery training program in the country and the world, as a matter of fact, headed by Dr. Albert Roten, a true pioneer and visionary in neurosurgery. And I heard for the first time patients talking about their proud flesh when I was doing histories. And I'm like, what the heck is proud flesh? You know, I know you guys are in the south and all. I'm just from the west coast of California, but we never heard of proud flesh. I didn't know what they were talking about. But it's basically inflamed tissue, usually in the skin, under the skin. So, any questions? Are we having fun yet, folks?
We do have a couple more questions.
Oh, very good. I'm going to be done in about 2 minutes, Dr. Pettit. So let's get this patient ready to wake up so she could walk out of here, figuratively. I'll take the questions.
We have another viewer on Facebook who's wondering, will the disc material that you removed during surgery grow back?
So will the disc material that I removed during surgery grow back? Folks, the disc material that I'm removing is not normal disc material. No, it will not grow back, not the jelly, but the outer part that's torn that I'm debriding right now, this will grow back, yes. But the jelly will never grow back. The jelly in the center will never grow back. You are born with that jelly, you know, it was the notochord, as I've said before, and now it's just an embryological remnant, and it really serves only one purpose, to act as a shock absorber or cushion in the center of the disc. So you not having it, you're really not going to miss it, to be quite honest with you. And we always talk about the jelly as being a cushion or shock absorber, but the truth is, it's really, you ever watch those movies where there's I like to watch horror movies, okay? I've been watching horror movies since I was a kid. And you know how, like, there's the kids, they're out in the forest, they find the cave, they, unlock something, and then the monster is released, right? And the monster comes out and gets them. You guys know what I'm talking about? Or like Indiana Jones, was it Temple of Doom? No. The one with the Ark of the Covenant, when they opened it and then all that death and destruction came out, right? As long as it was concealed away, everybody's fine. So everybody gets the point, right? Well, the jelly, the nucleus pulposus, is like locked away at the center of the disc, and as long as it stays there, it's like that evil monster. Once it gets out, it wreaks havoc, and it causes pain and suffering, okay? So the idea is somebody locked it away in the middle of the disc, and when you get a tear in the annulus and it lets that jelly out, that jelly then wreaks havoc like a monster coming out of its prison. Vampire movies, they all the same. But once it gets out, man, it causes pain and suffering. Okay, now some people are able to address it, and their body fights it, and they wall it off and re-imprison it. So it's not accessible to the inflammatory system anymore. But for a lot of people, their body is fighting it for years and years and years, trying to put it back where the genie back in the bottle, so to speak, okay? And they're not able to. So I come in with my laser and I zap it away. Basically, I fight these monsters, and then the body heals and seals it off again, okay? And that's pretty much what we're doing. So a lot of people are able to heal their herniated discs so they don't cause symptoms, but a lot of people are not. So I would say the majority of people heal their herniated discs, because every single human being alive over the age of 40 has herniated discs. I mean, I've seen even kids with herniated discs, okay? And so the ability of one person to heal that disc and seal off the jelly that's when your pain goes away. And it may take a day or two, it may take a week, it may take a month, but generally once you get past a month or 2 months, that's it. You're not getting rid of that pain on your own. You need help. You need me to come in and be the Ghostbuster with my special tools here. Okay? Yeah. Think about it. That's what we should call ourselves, Luis, Ghostbusters. That's what we are, folks. We're Ghostbusters. Think about Ghostbusters, right? You got these horrible things out in the city causing problems for people, and you got the Ghostbusters. If you don't know what I'm talking about, go watch the Ghostbusters. It's an old movie from the 80s. So these guys come in, and girls, and they capture the ghosts with the machine that they create, and they're not supposed to do much harm to the city during that process of fixing the monster issue, The other option is you could bring in, nuclear bombs and tanks and jets dropping bombs on the city, but that would cause a lot of collateral damage, and it probably won't catch the monsters. So what we've done is we were like Ghostbusters. We've developed a tool that can be used to get rid of the monsters causing back pain and neck pain. And we're helping to recontain them so that they can't be out causing mischief. I don't know. Sometimes I get bored and I make these analogies, but hey, I'm paying for the show. All right, that's pretty much it. Let's see. We'll take some more questions or save them for me to come over there and directly answer them, whatever you prefer, Sean.
We don't have any others currently.
You don't have any questions currently?
Correct.
All right, very good. Well, we're done. Scope off. We'll show you the incision that was used to fix this patient's L4-5 disc herniation. It's the same incision we do for everybody when it's in the lower back, lumbar. It's from the side. It's called transforaminal. Trans, again, means through. Foraminal means through the foramen. That's how we get to the tear, by going through a hole that's already there. So we're not making new holes in the spine, Most spine surgery, traditional spine surgery, is performed by making holes in the spine. Those holes are called laminectomy, laminotomy, partial facetectomy. Those are all very damaging holes made in the spine. So this is a way to fix a spine without creating holes and removing bone from your spine. The only reason those other surgeries are still done is because the surgeons don't know how to do the surgery, and they don't have the equipment to do it.
Okay.
And of course, they make more money doing those other surgeries. So, all right, push here.
Yes, sir.
Okay, write your questions up, folks. We're done. Luis, you want to show them the incision? Take a look right here. 7mm incision. No bone or ligament removed from the spine. No destabilization of the spine from the surgery itself. Patient's going to go home in an hour. And I believe her pain in her back and leg are gone. That's pretty common and typical for this type of surgery. It's curative of back pain and curative of neck pain if we're doing your neck. And we started doing thoracic disc herniations a year ago, and we've had 10 of them now with no complications. Everybody goes home, it's outpatient, and it's 100% relief of the thoracic pain. I'm going to call the EBL 1 mil. Go ahead and type up your questions, folks, and I'll answer them for you. Well, hello. I'm Dr. Deuk Machen. I am the face behind the organization and the surgery you just watched, which is a revolutionary new surgery in spine. And it was developed here at Deuk Spine Institute by myself and my team. We have published the surgery in the basically journals, medical journals, which is where you're supposed to publish. The name of the journal that we published our original papers was Surgical Neurology International. What's special about Surgical Neurology International? Number one, it's free, open access. We published back in 2012. In 2012, most of the medical journals, when you publish new discoveries and peer-reviewed research, which is what we did, Those journals cost money. So if you're somebody who wants to read the paper, you'd have to pay a couple of $100 to read the paper, or if you're part of a medical institution, they may pay for you. But it basically costs money to get a copy of the paper. We didn't want people to have to pay. We want it to be free and open access to everyone to use and learn. So we published in Surgical Neurology International, which is a very reputable journal. At least it was, until Nancy Epstein got in charge of it, which she's just a complete idiot. But Dr. Osman, Jim Osman, was the former professor emeritus at UCLA in neurosurgery. Smart man, caring man. He was the one who really the force behind the journal. Unfortunately, there are much lesser people. If there was a troll in neurosurgery, it would be Nancy Epstein. Sorry, Nancy, I have no respect for you. So if you listen to this someday, you know, it's the truth, and somebody needs to tell you. But long story short, it doesn't matter. What matters is that it's been peer-reviewed and published. We know the outcomes of the surgery. I've been doing it now for almost 16 years, and every single patient I've ever done in 1,300 plus patients has had excellent, like 100% relief of their disc pain and arm or leg symptoms. And so it's really a miracle surgery to cure back and neck pain. I stand behind it 100%, and more people are learning about it, and they're avoiding very dangerous open back surgeries like microdiscectomy or laminectomy or fusion or artificial disc. You don't need any of those surgeries, folks. They're highly invasive, big incisions, scar tissue, complications, metal implants in your spine in most cases. You know, there are 2 million surgeries done last year in the United States alone with metal implants, with fusions and spine devices. Totally unnecessary, 100% of it unnecessary. Well, I shouldn't say 100, let's just say 99% of it unnecessary. And it's all being done for exactly the same problem we fixed today in this patient. By the way, our first patient, the Canadian, she's ready to go. She's literally grabbed me in the recovery room. She's smiling and laughing and giggling. She says, I can't believe it. My pain's gone. My leg pain's gone. I'm so happy. So we're going to see her in just a few minutes, and we'll do a testimonial of her. But you know, you make the right diagnosis, you do the right treatment, and patients do very well. We don't need to believe anymore that back pain and neck pain are uncurable. They are 100% curable as long as you find the source of the back pain. In the case of these patients today, the source was herniated disc with annular tears. The annular tear is the source. The herniated disc is part of the process, the disease process, and all of it's totally fixable without open back surgery. It can be done with an incision, 7 millimeters, Band-Aid, outpatient with a 30-minute recovery. Okay? Sean, do we have any questions?
Doesn't look like we do. No new questions in the chat.
We had some great questions. Thanks for the coffee. Great questions today from our audience, very insightful, and we gave the answers during the live stream. Now we're going to go check on our post-op, our Canadian patient.